Hello and good evening to you. We're here at the ESC Congress, Monday the 27th, and what an amazing day we've had. Packed sessions, really exciting new trials, and I'm with key experts who are going to give me some insights into these trials, strengths, weaknesses, what are the implications. Deepak Bhatt, Michael Berm, Marco Roffi. So let's start off with one of the big trials that was lighting up the hotline session. And Deepak, you wrote the editorial, Global Leaders.
Yes, so first of all, I've got to say an extremely well done study, so congratulations to the investigators on that, and congratulations to the ESC for landing all these incredible late breakers. The trial randomized patients to aspirin and ticagrelor for a month after stenting, followed by daily ticagrelor, not aspirin. And the control arm was a year of DAPT followed by daily aspirin. Now within the control arm, a little bit of complexity to the trial, those with stable angina getting stented got aspirin and clopidogrel as their DAPT, and those with ACSF with the stenting got aspirin and ticagrelor for that first year, then aspirin thereafter. So a couple of different flavors in terms of duration of DAPT and types of DAPT. But nevertheless, the overall trial didn't find any significant benefit to the new regimen. What's that?
There were trends for benefit, but didn't quite reach significance.
Yes, the primary endpoint p-value, wasn't less than 0.05. So strictly speaking, the study didn't meet its primary endpoint. There certainly were trends in there, but given the greater cost of ticagrelor, twice daily dosing, dyspnea, greater rates of discontinuation, I think the standard of care remains as is. Actually, the title of my editorial was that aspirin is the global leader in antiplatelet therapy for secondary prevention, and I think that remains the case. So the standard of care, DAPT for a year after ACS, DAPT for a year after stenting, that might not quite be the standard care. Many people say 6 months, but in high-risk stented patients, a year is reasonable. I think that should remain the standard of care. And while this idea of de-escalating from DAPT at a month and going to ticagrelor monotherapy is quite intriguing, global leaders didn't quite prove that was the way to go. But the Twilight trial is ongoing, examining a similar sort of comparison of the de-escalation to ticagrelor monotherapies at 3 months in that trial.
So Deepak, we're in the twilight zone of de-escalation.
Very good.
And at the moment, aspirin is the standard of care with DAPT, post-stenting and after ACS. Michael, agree, disagree?
I agree completely. So indeed, this is a moving target, and so we're going to see more data.
And what do you think, Marco?
I think quite puzzling the fact that actually after the first year, if the trial would have been stopped after the first year, then it was significant for death and non-QA myocardial infarction, while at 2 years is lost significance. So I'm quite intrigued, and I would like to be interested to see what Deepak think, why there was no benefit in the second year. This would have been expected based, for example, on Pegasus study.
Yeah, I think you're right, though. Of course, Pegasus was aspirin plus ticagrelor versus aspirin plus placebo. Here, in that second year, it's essentially aspirin monotherapy versus ticagrelor monotherapy. And I think that part of the trial is consistent with other trials that have not shown that ticagrelor monotherapy can beat aspirin, for example, in the Socrates trial of stroke.
And in Euclid.
Yes, in Euclid.
Peripheral artery disease.
Right, where clopidogrel was the comparator as antiplatelet
it
monotherapy.
was very similar.
That's right. So as part of DAPT, ticagrelor does seem to do well either in the ACS patient for 12 months or even beyond in the post-MI patients in Pegasus. But as monotherapy, still needs to be proved before we use it.
Following the discussion, it was discussed that at the second year, ticagrelor, many patients went off the drug. So adherence to the drug in the second year was worse. So this is a pity. Otherwise, we would have more clear results in the second year as well.
So there could be a dilutional effect.
A dilutional effect on the endpoints.
Okay,
right.
but the take-home message for the cardiologist is the current conventional DAPT is still the reference standard.
Absolutely.
Okay, terrific. Now, I know, Deepak, that you were intrigued by some of the pathological and other findings from an interesting PAD study by Dr. Narula and colleagues.
Yes.
Give us some insights into that.
Absolutely, and I should disclose I'm a co-author on that. The first author was Dr. Navneet Narula, a pathologist in New York, Cornell. It turns out one of the other co-authors was Dr. Jagat Narula, who we all know. the cardiologist from Mount Sinai, as well. Renu Vermani validated all the pathological work that was done in this pathological study. Dr. Navneet Narul is a pathologist. So what was examined here was patients who had amputations and really careful sectioning of their arteries to see what was going on in the arteries of these people that ended up needing an amputation. Obviously, they had bad peripheral artery disease, and what was found was atherosclerotic plaque calcification, things that one would expect. But what was, I thought, quite intriguing was the high prevalence of thrombus that was found in these lesions. And to the best of our knowledge, these weren't people with AFib or undetected AFib, as best one can tell, but rather it was thrombus in situ or atheroembolization from thrombus that had formed on plaque upstream.
Right.
So I believe that this provides a lot of potential insight into why, for example, in COMPASS, the combination of aspirin plus low-dose rivaroxaban not only reduced MACE, but also reduced major adverse limb events, including amputations, quite importantly. And also why in other studies, Pegasus, for example, in a post-MI population, in the PAD subgroup, aspirin plus ticagrelor reduced MACE, but also reduced peripheral ischemic events.
So really interesting results and insights potentially into some of the mechanisms of events in people with peripheral artery disease.
Yes.
So thank you for that. Now, one of the other big studies presented was Commander. And Marco, you're going to give us some insights into that.
Yeah, Commander HF is a study on 5,000 patients with heart failure, ejection fraction less than 40%, coronary disease, but in sinus rhythm.
But these are people who've had quite a severe heart failure deterioration with hospitalization.
Exactly, this is a good point. And so these patients were randomized to standard of care, which is antiplatelet therapy, or standard of care plus rivaroxaban twice 2.5 milligram. And the patients were followed up to 2 years, and the primary endpoint was an ischemic one, death, myocardial infarction, or stroke. And with some surprise, there was absolutely no benefit in terms of ischemic events, while the price to pay was a 70% increase in STH major bleeding.
Yeah.
So obviously this is a deception. So we may have thought that maybe there is some atherothrombosis playing a role or undetected atrial fibrillation in those patients. But this study clearly shows that adding low-dose rivaroxaban is not beneficial and even harmful.
But this is a particular population who've got severe heart failure and they've had a hospitalization. So many of their events are heart failure related deaths. And if one looks at the individual endpoints, you said absolutely no effect. I think you're not quite right, because if we look at the strokes and the MIs, there is exactly the same trend as shown in COMPASS.
Although I would be, let's say, very, very careful, because stroke was not even a secondary endpoint in the study.
Sure.
So it was far, far down.
Sure. I'm not saying it's an outcome, but we've got insights into why the study is as it is. Okay, thank you.
Comment on one thing there,
Yeah.
Because you could interpret, as Marco did, that just a negative study. But like you mentioned, there's some positive signals. Now, I'm certainly not recommending using that regimen in heart failure patients. Heart failure deaths are what I think killed those people, and an antithrombotic is going to have limited effect there. But on the other hand, going back to COMPASS, there the heart failure subgroup looked terrific in terms of benefit. So at least in the presence of I would say high-risk CAD or PAD, when there's also a history of heart failure, not acute decompensated heart failure, there does seem to be a role of the combo of aspirin plus low-dose NOAC.
So that's going to need unraveling over the course of time and thinking about. Now let's just discuss briefly amyloid, the ATTRACT study.
So ATTRACT, I think this was one of these studies which was really a true innovation.
Yeah.
So these transthyretin amyloidosis affects more patients than expected. So there was a pre-discussion question to the audience, and 40% said it's a very rare disease, but this is not true. It's an underdiagnosed condition, which is approximately present in 15 to 20% of all the patients we are doing Itavi on, and it is also one of the significant causes of heart failure with preserved ejection fraction. And this is an untreatable disease, so it has an approximate and average survival time of 2.5 years, so it's a malignant disease which is highly symptomatic, and so this is something which was not treatable before. So this trial was done in 400 patients approximately, and it looked at the survival rate of a drug called tafamidis at 2 doses, 20 and 80 milligrams, to improve survival and also physical exercise tolerance.
But essentially it was a mechanistic study.
It was a mechanistic study, and it was not, obviously, it's a rather small number, but the high death rates gave quite clear results. So there was a 40% reduction of mortality. Interestingly, the curve separated only after 1 year, which is quite plausible for biological mechanisms because this drug stabilizes the transthyretin, that the misfolding of the protein is inhibited. So then it shifts the whole equilibrium more to the degradation of amyloid in the heart. So it is quite reasonable that it takes the time. And so this is a clear result on mortality, but what me expressed most was that there is a reduction of walking distance of 30 meters per 3 months.
And when you say reduction of walking distance, I thought it was an increase in walking distance.
No, it was a reduction of walking distance, 30 meters in 3 months. That is a disease. And this was inhibited by 80%.
Exactly.
So the curves were exact. When you can roughly see that it's inhibited by 80%, so it's improved by 80%. But this huge drop in physical exercise reflects that it's really a malignant disease.
Okay.
So I think the results are clear, although there are small numbers. What intrigues me, it is approved in Europe, it is 800 euros a day. So if we diagnose this condition properly, it will impose really a huge burden on our healthcare system.
But
so
mechanistically really exciting and
innovative.
Okay.
Absolutely.
So very briefly now, the MITRA study, percutaneous mitral valve repair against standard of care medical management. Marco.
Yes. So these were 300 patients actually in heart failure, depressed LV function with functional mitral regurgitation that were highly symptomatic, and they were randomized to optimal medical treatment, or they were randomized to percutaneous mitral clip. And again, with some deception, there was absolutely no benefit from mitral clip in terms of death or rehospitalization for heart failure.
Okay.
So I think that the field needs to be reassessed. And so once again, probably is the myocardium the most important thing, and unfortunately, just fixing, let's say, the mitral regurgitation doesn't change the outcome of the patient, although technically very successful, very low complication rate, and also in terms of residual mitral regurgitation, excellent results.
So if technically you fix the mitral valve, but you've got a leaking mitral valve because you've got a damaged ventricle and a stretched valve, this hasn't improved outcome. Okay, very finally, MATRIX.
Yeah, MATRIX, we have this year the 1-year result of the MATRIX study. Just to remember, the MATRIX study is an 8,000 patient with acute coronary syndrome, randomized transfemoral or transradial approach that show at 30 days the primary endpoint was a very positive one with a reduction in ischemic events and bleeding events, and set the foundation for the class 1 recommendation in latest guidelines. So now we have the result at 1 year, and this shows that the benefit is maintained with a reduction in net adverse events in terms of death, myocardial infarction, stroke, or BARC 3 to 5 bleeding. So the good news from there is that the benefit is maintained at 1 year.
And here's something that is clearly a practice changing, if people haven't changed already, in terms of their practice. So I think we've had a fantastic day. Thank you for your tremendously interesting insights, and enjoy the evening and enjoy tomorrow. Thank you very much.